My name's Rebecca Stone, and I am the Business Solutions Manager for the HIE team, and I will be the facilitator for today's webinar. We're definitely excited to welcome two distinguished speakers, Stephen Miller, who is the Chief Technology Officer and State Coordinator for Health Information Exchange at the Oklahoma Healthcare Authority, as well as Dr. David Kendrick, who is the CEO of My Health Access Network, which is also the Oklahoma state designated entity for health information exchange. So today's webinar, we're going to be focusing on integrating electronic health records with the health information exchange. For those who may have joined a little late, we will address all questions at the end of today's presentation, as well as share that presentation. If you do have any questions, please use that Q&A function. Those questions will be answered live and may not appear right away, so just keep that in mind as we go throughout the Q&A process. At this point, I'm going to turn it over to Stephen Miller. Stephen, if you want to go ahead and share your screen.
Muted. Hey, thanks for allowing me to speak to you today. As Rebecca said, I am the Chief Technology Officer for the Healthcare Authority, and I have an additional role as State Coordinator for the HIE. And we're going to take you through kind of an overview of the HIE and many different things that it offers, with some specific reference to how EHR vendors can get involved and providers can assist those EHR vendors in helping them get that connected. We have a group today of both EHR suppliers as well as provider organizations. I think the way we've set the content up today, it's applicable to everyone. So, and as Rebecca said, if you have questions as we go through, just put them in the Q&A and we'll get those addressed. So let me share my screen. All right, let me get started here. So I've got quite a lengthy agenda. It's actually only some of these are only a slide, but I just want to go through some of the purpose and why we need a health information exchange, as well as some history and background and legislation and how this thing's put together. I also want to walk through, for a huge amount of the time or a large amount of the time, the incentives that are available that can pay for your connection with your EHR vendor, as well as eligible provider incentives that can actually pay more, not only your participation fee, but more than your participation fee that the legislature has helped us develop. So let me walk through these, and Dr. Kendrick will be taking us through some of the technical pieces of this, and we'll wrap it up with what the value is. I always like to push this back because a lot of people say, you know, why is the HIE managed out of the Healthcare Authority? Well, these are some of our mission and vision statements, but I like to point out that this primary statement around enabling our members and providers and other stakeholders with information and services to make informed decisions. This is really what the HIE is all about, allowing you to have a better access to information about your patient, and for you EHR suppliers, allowing that information you may have in your EHR or need in your EHR to better flow between other providers and other EHRs. So why do we need an HIE? Well, it depends on which study you look at, and I'm actually kind of kind with 45th as in the nation around healthcare. Our healthcare is very poor. That's both healthier. We're not very healthy as Oklahomans, and we poorly coordinate care across our state currently. In fact, we are the 10th highest cost in the nation currently, which is pretty surprising given that the rest of our cost of living and so forth ranks in the lower part of those in the nation. And, you know, one of the things we believe is a major part of that is care coordination, and also that Oklahomans don't always understand what they're eligible for and can't get to the care they need. A big one is lack of preventative care. We don't have good ways to proactively notify. And one of the things you'll see today is the HIE can provide those proactive notifications so that you can ensure that those care gaps in your patients are met. Of course, adverse drug events affect more than 20,000 Oklahomans annually. And this HIE has one of the primary use cases to be able to see all the medications that a patient may be on when they show up in your office. And I like this stat is one of the most interesting ones that it surprises me. But despite Oklahoma having about at average U.S. cancer rates overall, the mortality rate is 20% higher if you live in Oklahoma. And again, we think that's more around care coordination and access to care. And overall, our healthcare system ranks 48th. This, like I said, varies. The lowest I've seen it is 48th. Highest is 45th. So it's obviously not where we want it to be. I like to go through what an HIE is. I think most of you on the phone or on the call today probably know that, but there's some things I like to point out. This is a good definition, but the things I'll say about it, this HIE in particular, is it's a very secure system. You'll see later all the technology and even the organization who manages this information is HITRUST certified. That HITRUST certification is the highest level of cybersecurity certification that can be obtained, and it has a very onerous not only qualification but also an ongoing management of that to ensure you meet those standards on an ongoing basis. The other thing that I like to point out is that to access the HIE, you must be a provider involved in a patient's care. I can't look up people at all, actually, as the state coordinator, but if I were a provider, I can't look up patients that aren't mine, that I'm not in a treatment relationship. And actually, when you access a patient, you have to state that attestation of what those are. And everything's done according to HIPAA. Actually, the rules that the state designated entity has here are more restrictive than HIPAA, but all those HIPAA guidelines apply, as well as all relevant state and federal laws. So, why do we need a health information exchange? Well, I think this is interesting, and later Dr. Kendrick's going to show you some very detailed information around this care fragmentation concept. But 90% of Oklahomans have records in more than one healthcare system. I know for me personally, I can count at least 5, maybe 6 different places that I've been, and so I want to be sure that I have access to those records, or that my providers have access to those records. And it's very difficult when you've got many EHRs out there without something like a health information exchange. And some of the things that helps, obviously, is reducing healthcare cost. That can be associated to redundant testing. If you could have tests that you can access in the HIE, you don't have to run that test again and find out that it's not getting paid for by the insurance company. It can reduce hospital readmissions. It can reduce emergency department visits. It can just overall improve that care coordination and transitions of care. I know when some of my family and my father went through some of his end of life things, he was going from specialist to specialist, oncologist to cardiologist to primary care. And, literally I was carrying a bag of records around with me, because every one of those, they'd ask me a question and I'd be like, "Oh, you don't have access to that? No. Okay. Well, let's see. Let's find that information in these records somewhere." And that's an experience we don't want our patients to have. And if we can do that, we can improve the patient's experience and the overall experience of the patient, as well as provide a better opportunity for the provider, because the provider can now have better insights into their patients, and actually we can help them perform better on their quality measures because they have quicker insights to those care gaps and so forth. And overall, we help comply to state and federal programs such as CMS interoperability rules. There are other programs that we're not going to talk a lot about today that have incentives for you to be able to qualify for, that get additional dollars than what I'm going to talk about today. And then lastly, we really just want to improve the outcomes and support healthier Oklahomans. And that's what, if we can reduce this these errors and these missed opportunities that due to care fragmentation, we can go a long way to having healthier Oklahomans. So I like to start out really with some of the common questions. The HIE, I joined the organization just about 2 years ago, which is kind of a restart of the Health Information Exchange in the state. And so a lot of these questions have evolved over time and a lot of questions we get publicly. So I like to just hit those. One of the first ones are that all the fees are set by the state designated entity. So in this case, my health is our SDE. They set the fees. Those are based on organization type and size. All the connection fees can be paid for through our connection fee assistance program, which we'll go into a lot of detail here in a minute. And there are incentives available for certain provider types that in most cases will exceed the annual cost of participation. These participation fees are not meant to be onerous. They're very economically sensible. They're just meant to help maintain the network. But I think you'll see that with these incentives, it makes a whole lot of sense to get in. It's not a better time to get into the HIE. Privacy and security, we'll get a lot of questions about that. I did mention already that providers have to be in a treatment relationship to access records. Of course, no substance abuse 42 CFR Part 2 type data or psychotherapy notes ever go into the HIE. Providers can mark charts or encounters as sensitive, and those aren't sent. So although you may be sending the majority of your patients, if you have a particular patient, particular encounter you just don't want to send, you can mark that as such. And then the security, I did talk about already, the high trust certification. They've been operating for well over 10 years. And the last thing I like to talk about is choice. Providers have a choice, patients have a choice. All patients have the right to opt out at any time. They can opt out either on our website, my health website as well, or any provider who is in the HIE can opt them out in their office. So, and I do like to talk about, we used to have a break the glass concept where the data was still available, but only in cases for ER physicians when it's a life and death situation. It's only happened a couple times in over 10 years. So we actually took that functionality away. So there's no disclosure. If you opt out, there's no disclosure of your record. From a mental health perspective, they have kind of the opposite of the opt-in, opt-out. All mental health patients have to affirmatively consent. So they have to actually sign a consent for any of their data to flow into the HIE from their provider. And lastly, providers have a choice. We do still offer an exemption. Basically, if you apply for an exemption, we will allow it, but we will encourage you, and we do encourage you to be a part of this because it can be a huge benefit to your practice. I'm not going to spend a lot of time on the history of the legislation. I think the most important things to point out is, 1369 was the big legislations that created my office. It created the concept that we would outsource this to a state designated entity to operate the HIE. It did set up some privacy laws and tort protection. I think tort protection is a big thing to know, that if you're a provider and you make a decision based on information in the HIE and it's wrong, you can't be sued, and the vice versa of that. If you don't use the HIE and there was data there that might have helped you, you can't be sued. So that's a very big provision that we have in the law. 1337, I like to point out, all the managed care entities and providers are required to submit data to the HIE. And then 3556, we changed the concept of all providers shall, meaning everyone was required to be in, to all providers may. So it is optional, as I said earlier. Okay, incentives. Let's talk a little about incentives. So the big one, and this is really clear, I want to make clear to both the EHR providers as well as the organizations that are online, that so basically the legislature 2 years ago granted us $30 million. They reduced that to $21 million. We have a substantial amount of that still available. This is for all connections. So that, and David will go through, or in a minute some of that detail on the connection types and so forth. But generally speaking, everything from your HL7's connections to your SSO connection all can be funded through this grant. It's simple to apply. Just if you see that connection fee application there, the orange button or box, you can pick that okshine.ok.gov, and you can complete that application, and that gets you in. And I highly encourage you, if you're not already connected or you're not already in the list for the connection fee, get in, because this, as you guys know well, the legislature is going to be a lot of demands on funds. And so, we always have a possibility. There's never a guarantee that this is going to get extended. So if you get your connection fee application in, and you get started, at least you get to the point of a kickoff meeting, then we can guarantee that you're going to get that money. We'll be able to encumber that money. So we highly encourage you to do that if you can. Okay, so this is kind of where we are. We've encumbered just about $3 million. We started this program in January of this year. You can see it's had a pretty steady growth. I think we're actually in the 380 grant range just in the last 2 weeks. So it's continuing to grow. So we continue to hope we'll get as many people in the queue and connected as we can. The other thing I wanted to talk about is the provider incentive. So Sooner Select. So if you're in the Sooner Select managed care program, if you're a provider that's contracted with that, you have an additional incentive you can be eligible for. It's a pretty wide provider types, and I'll actually go through the detail of all these. It's doctors, advanced practice nurses, mid-levels, all mental health providers, anesthesiologists, and so forth. There are a few exceptions to this. Mainly those behavioral health and mental health professionals who are in a community mental health center. Those are excluded. State employed and contracted physicians are excluded. And FQHCs and IHS type tribal areas are excluded. And if you service the Medicaid population not transitioning to Sooner Select, such as the ABD population, those are also excluded. So here's way this works. So you will receive up to a 28% increase in your base fee schedule reimbursement. So just for being in Sooner Select, you'll get 18.5% base fee increase for a provider participating in that Sooner Select program. And then if you're a member of the HIE, you'll get an additional 9.5%. Now there's some requirements, but they're pretty simple. The requirements are that you send data and you utilize. This is what CMS asks us to do. And to do that, you just really need to be a member in good standing. So basically, you've signed up to be an HIE member, and you've either become live with your connection or you're in progress. So literally, in a day or so, you could sign up, sign your agreements, and get on the list for connection fee and be in the queue, because it might be months before you actually get connected once you work with your EMR vendor and so forth. But you would be eligible immediately for the next quarter payout of this. So this program started in April of this year. So that first Q1 was April to September. And in these particular quarters, we're not requiring any utilization metrics. So if you just have those two things, you're either connected or in process of a connection, and you're a member, you will get the payout. Note in the future, we're considering, because the whole idea is not only to get people connected, but also get people using the system. So we may be adding some requirements for that around how much you use it. It'll be very, very not onerous at all. We're not talking about, you use it on every patient. We're talking about just a very small percentage that you start kind of walking before you run and got your feet in the water of how you use this. Okay, here are I'm going to flip through these really, really fast. These are the actual provider types and specialties that are considered under those provider types that are eligible for this incentive. And you can see it's a pretty wide group. Flip through those. and you'll have this list in the presentation that we share. Again, I just point out those exceptions as I went over earlier, and here's kind of another way to look at exclusions. Now, there are other, I don't talk about this, but there are other payouts for like expert screenings and things like that. So if you go to our website, the Healthcare Authority, and look at the Center Select Directed Payment Program, there are other payouts for other services that are part of this program as well. Okay, so I want to talk about a little bit about progress and framework. So if you've been following the HIE much, we've really grown over the last 2 years. We kind of restarted in September of 2022. We're averaging approximately 50,000 unique patient records accessed monthly. So that means that a patient record might have Steve Miller might have been accessed 50 times by different providers, but that counts as one in this list. And that's 50,000. That's up. That's over 200%. We were under 20,000 in September of 22. So that's really growing. This number has jumped to the 70 and 80,000 in some months. So we're really starting to see a lot of people using the system more and more. There's over 450 organizations actively participating in the HIE, over 1,500 locations. 178 organizations joined just in the last year, July of 22. So we really doubled that. All the Sooner Select dental and medical MCs are contracted, trained, and connected. So their care managers in particularly use this system on a regular basis. OHCA has been using this system for their care managers really for the last almost since its in inception. So 7 or 8 years. We've been using that system. We do have the capability to send ADT and care fragmentation alerts to those MCEs. Several of those have elected to receive those. We do that. So every night at the Healthcare Authority, we get a feed from the HIE that tells us what of our patients landed where, in an ER, in a hospital, wherever that might be. And then that's risk adjusted and sent to our care managers who do follow-ups immediately. Our care manager who manages that area, she has said many times, I don't know what we do without the HIE. I guess we'll be waiting on claims for 30 or for 45 days, which wouldn't do the patients a lot of good. They're able to follow up real time. And not only that, they know what happened. They know what their conditions are. They know what they're dealing with. So it's a very powerful approach. Connection fees we've granted. This is 361. Like I said, that just jumped over 380. Over 200 organizations are actively working on connecting. We're optimizing that process. And that's one of the things that as we work with the EMR suppliers, we really want your help to optimize this. We've got some EMR that we can connect to literally in hours and some that take months. So we really want to figure out how can we streamline this? What can we do on our side to make it easy for you to connect and get your providers connected? We think there's a lot of value there. And of course, like I said, EMR connection fees. So those fees that EMR supplier will charge are covered. So the state will cover those. Now there are limits. It's not an open checkbook, but in general, any reasonable fees for connections will be paid for. And then I do like to talk about that Center Select directed payments. So plan Q1, that's that April to June. The payments have been calculated and payments went to the MCEs in late September. So actually, I think I needed to update this. I think we had some issues that actually went out in October, but those MCEs have 5 days to issue the checks. I think they actually sent a physical check, which slowed it down a little bit. But so if you're a provider and you qualified for this, you should probably be getting your check. If you didn't get it the last day or so, you should be getting it this week. So if you're not, probably need to follow up with the managed care. It is a little bit, even though you may be contracted with multiple managed care entities, Aetna, Community Care, whatever it might be, Oklahoma Complete, I'm sorry, or one of those, you will get a check from one. So you might get your check from Aetna, and it will incorporate all the all the reimbursements that you sent through all the MCEs. So just don't be confused by that. And we'll be sending out some letters to clarify what people actually received and so forth. Plan Q2, that's current quarter. Of course, we only have a couple weeks left here. If you can get in, that would be great. Actually, I guess it's actually closed. I'm sorry. So we have closed that quarter, but I encourage you to get in as soon as possible because we've got the rest of this next quarter to go. We aren't making any changes in the qualifications for Q3. Actually, that October to December that we're in now. We've made a decision. We won't be changing that utilization requirement. If we do, it'll probably be in the January fourth quarter of this plan standpoint. This payments do go out until June of 25. So I just want to point that out. So there's quite a bit of dollars there. We just paid out in this run. We paid out a little over 11 million, almost $12 million to those providers. 2 million of that was HIE related. And so if you do the math, this is a $134 million program, and we will be required by CMS to issue all of those dollars. We want to give this money out. But we want people to make the progress that we need. But it's a good chance that those percentages I showed you earlier of 18.5 and 9.5 could actually go up as the program reaches the end. I showed earlier, this is a pretty good map. It kind of shows you all the locations that are in the My Health network and the HIE network. It's the state is very well covered, and I think when you see what Dr. Kendrick shows you here in a little bit, you'll see our data density is quite incredible. A little bit about how this works. So this framework, you can see here at the bottom, all the providers and provider organizations send their data up through what we call our data gateway layer. This is a vendor agnostic layer where the data gets initially stored, then it gets processed by the state designated entity, of course, in this case, My Health. And of course, what they do is the primary thing they do is manage all the day-to-day operations of the HIE, but they also do member governance and execute agreements, they establish fees, all those things. Now the state's a part of that, but that's their primary duties. They also operate the technology layer. The technology layer is where our portal lands. All our single sign-on integration, and we'll show you an example of that in a minute. This is a super good technology that we want to see all of our EHR vendors support, as well as all of our providers take advantage of. David will show you more about that in a minute, but it's basically the ability to, from inside your EMR, when you're in a patient's chart, to hit a button and in context pull that same chart up in the HIE. No login, all that's passed through, all that happens. Really convenient. And then the Office of State Coordinator provides all the program oversight. We coordinate all the other state agencies. We do some reporting and analytics, and we manage the funding sources, which seems to be lately what we're trying to do the most of, because I think that we're a lot more success with carrots than we do with sticks. So we want to continue that. So I'm not going to spend a lot of time on this, but sometimes like to compare this. What does the state do versus what does the state designated entity do? Like I said, the main difference is we are really the oversight and the management entity of the state designated entity who does all the operations and works with the participants and gets them onboarded, trains them, all those type things. I might also mention that OFMQ is a big part of what My Health is utilizing to help with some of this. And they're doing a great job also with helping organizations understand how to get going with this. What are users saying? I think we have a library of hundreds of these testimonials, and it always amazes me what kinds of things happen out there. I don't know how much, many of you may not even know what a Net Promoter Score is, but this is how technology companies manage their customer success. And a plus 34 is incredible. I'll just give you an idea. I used to work at Cerner, and when we got +1, we were like having a party. So, but Apple Computer, this is the kind of range when you get in these plus 34 or higher. This is like that kind of customer success. So here's some examples. Hope you have time to read these. I mean, all kinds of use cases for this. I mean, from a behavioral health to care coordination, care managers, actual providers, and nurses and physicians. They all say kind of the same thing, that this really helps me do things I never could do in a real-time manner. This is also from our MCEs, Aetna and Humana here in particularly. They're showing some of their ability to pull that chart and see diagnosis and create care plans based on that. Same way with some of these others that really trying to just help with the transition a member has from one care condition to another. So there are so many use cases of this data. Once you have access to that chart that shows us the complete view of the patient and where they've been and so forth. So I believe at this point, I'm going to turn this over to Dr. David Kendrick. He is the CEO of MyHealth, and he's going to take it from here.
Great, thank you, Steve. And I really appreciate that wind up. Next slide, please. So MyHealth has a number of capabilities, as Steve was alluding, and we can talk about each of those individually, but they're fairly common across what we'll call health data utilities, health information exchanges. I'll just point out a couple. One is public health reporting, being able to report things, especially during the pandemic, for example, but also to help providers make a lot of their required public health reports, both to local agencies as well as the CDC itself. Social determinants of health screening, I'll talk more about in a moment. But we also are the voluntary all-payer claims database for Oklahoma, and so we have about 2/3 of the covered lives worth of claims data coming into the MyHealth system on a monthly at least basis. And then we do care gap management, support quality programs and initiatives, and so forth. And next click. I do want to emphasize the point Steve made a moment ago, that even though generally speaking, we're talking about live data feeds from EHR vendors into the MyHealth system, we also really need to emphasize the importance of facilitating workflows so providers have convenient access to the data in the health information exchange, and that is through the single sign-on. We'll talk more about that in a moment. So this strategy essentially makes one-click access to not just the portal, the provider portal in MyHealth, but also to the context of the specific patient that was being viewed. And the goal there, as you'll see in a moment, is really to help providers be aware of all the fragmentation in their patient's care and be able to deliver comprehensive care and services, taking into account other medications or allergies or maybe other specialists that are involved in the patient's care that they need to coordinate with. Next clip. So as Steve indicated, we have a number of different products, and Provider Portal is one that's most commonly used by providers on the front line. That is where care managers, providers themselves, staff, and so forth that have the appropriate roles and access can pull a patient chart. And what's a little bit unique about the Provider Portal here versus other methods of interoperability like eHealth Exchange or Care Everywhere or Commonwealth, or even TEFCA, I see that alluded to in some of the questions. Those are models that are what we call federated, where you've got to go and get the data. And what you get in response to those queries are going to be documents. So continuity of care documents, generally speaking, that need to be read. And speaking now as a physician myself, when I'm taking care of patients, I just don't have time to review 10 documents to try and find the latest blood pressure or the latest hemoglobin A1C on the patient. So what MyHealth does is take in all of those documents and digest them to provide a single common list of medications, a common list of allergies, lab results, and so on. So it's a one-stop shop for the provider, and certainly when paired with single sign-on becomes the most efficient way for providers to quickly find comprehensive well-organized data on their patients. Next click, please. And so this is a map that just kind of shows you the level of data fragmentation for patients that a lot of people don't really recognize. So what this is showing is it's a map that shows a number of the health information exchanges or health data utilities. We can talk more about that term later if you want. And you see there on the right a list of them. Obviously, it's not all of the ones in the United States yet. They're still sending us the data to put this map together. There are about 75 altogether. But what's highlighted there in the map is just one specific zip code in the middle of Oklahoma. And it shows some important things. One is that they're more than 200% of the actual census population, which means that patients have fragmented records. They've got data in multiple places. Especially across other organizations and networks. So what you can see there in that little pop-out box is you see My Health down the list there with, say, 83, almost 84,000 unique individuals in that zip code, which is above the census count because people move away and don't have their addresses changed in the system and so on. But also look at the count of other networks around the country where those patients have received care. That means that they've gone to one of those other regions of the country. Even though they live in Oklahoma, they've received care in these other places. And so it's important not just that we are interoperating within Oklahoma with you as EHR vendors and clinics in Oklahoma, but also with the other networks around the country to provide complete data. Next slide, please. So this is a bit of an eye chart, but just an overall picture of the organizations already connected to My Health. These range in size from a one provider clinic all the way up to a multi-billion-dollar health system. So it's just a lot of organizations. I won't dwell on it. Next slide. But what is of interest, I think, here is how rapidly the network is growing. 135 new organizations since July of 2023. And that is accelerating as well, especially given the limited time funding that's available from the state. We want to make sure everybody's able to take advantage of that. Next clip. So this is that last map, but limited only to Oklahoma to help communicate just how fragmented patient data can be. Red indicates 100% of the population covered. And the other zip codes around the country indicate just how many other places patients have come from that have been in Oklahoma at some point and received health care, because our data that we're reporting from only includes Oklahoma provider organizations. Next clip. And so this is a chart that I build, and I'll take a minute to explain it. What it shows is, as you probably know, My Health has a master person index, and when data comes from multiple sources on the patient, we can use algorithms and identifiers to tie those records together so that no matter how many places the patient has been for care, they have only one chart in the My Health system. And what you see here are 6 different health systems in Oklahoma. And across the bottom are numbers ranging from 1 to 35. That indicates how many places patients have records. And so if, for example, we take a look at column at the 4 there on the histogram, you can see that health system F has almost 15.5% of their patients they take care of have data in 4 places, right? So what that means for me as a healthcare provider is, if you can go ahead and click one time, there you go, is that when a patient walks into my emergency room or into my clinic, this percent in the 1 column indicates what chance there is that I don't need data from outside, because I've got 100% of the data in my own health system's EHR. And you can see that that's a pretty small chance. It ranges from, 95, 96% of the time to 99, 98% of the time that I'm going to need to take a look at data from outside my health system in order to provide comprehensive, well-coordinated care. And that's the goal, of course, of having, first of all, the data coming in to the health information exchange and then making it rapidly available to the providers at the point of care via single sign-on. So a lot of folks say, well, that's all well and good, but we're using Epic or Cerner or some other system, and we're connected to the vendor's interoperability network. Does that cover me? Next slide, please. And so what this shows is the 6 most broadly deployed EHR systems in Oklahoma. As you'll see in a moment, there are many more than this. But this is showing the same data, but by electronic health record vendor. And it makes an assumption, which is a bit of a broad assumption, that if the data is in that EHR vendor, it's available to all users of that EHR vendor. But you all will know it's not automatic when I'm using the vendor networks like Care Everywhere or Commonwealth, etc. I still have to point to a specific facility to do my searches and pull data back. So click here, and you can see that this percent chance that I don't need to look outside ranges from, again, 96, 97%, all the way up to 99% chance that I need information from outside my vendor space, because patients don't choose their doctor based on the EHR they use. They choose their providers based on what's convenient nearby, who they trust. Next click. So one other point I wanted to make from the perspective of the network, we want all providers to be successful, and we want to help you all as vendors, if you are EHR vendors, to be able to successfully provide good service to your customers. And so what we observe is that generally the calendar is our worst enemy in building these data feeds, especially with the time limitation on this funding availability. This is a chart, next click please, that I want to highlight the number there at the bottom, and that number is, you can see there are 2. This is essentially how much of the total time it takes to build a feed is spent waiting on the client to do something, and usually their EHR vendor, versus what percent of the calendar time is spent on with the MyHealth team actively able to do work. As you know, it's a two-sided, and in the case of your customer and yourselves as a vendor, a 3-sided relationship. And so we try to do the best we can to coordinate, to facilitate things. But what this means from our perspective is it's great if we have a good point of contact with you as a vendor organization, and we are happy to group up or bin all of your Oklahoma customers into one feed building effort so that we can make it go more efficiently for your team and for our team and for your customers. But you know, we're open to any ideas that help balance this out a bit more and enable us to make sure your customers are getting the benefit of those state dollars while they're still available.
Hey, David.
Yes.
I just want to make one point to this. Even though you're seeing this, 73% versus 27% of the time, the actual time that it takes for the EMR vendor is much, much lower. It doesn't take 73% of the overall time. It's just by the, all the logistics and trying to actually get scheduled. And that's what we have to figure out, is how can we make this simpler so that the time you're spending connecting is a very small amount, and so we can get this overall percentage way down.
Yep, absolutely. It's a great point. And so we're open to any innovative approaches or ideas you guys would like us to consider in making this go more efficiently for your organizations. Next clip. So here are some of the EHR vendors that are already connected to MyHealth. Most of them should be recognizable to you, but I can tell you that list is quite long now. I think north of 70 different vendors that we have in the queue that need to be connected going forward. Next clip. So how does the connection process work? This is really the bread and butter here. This is probably, if you're an EHR vendor, this is probably nothing new to you, but I want to walk through it in any case. So the first step, of course, is that your customer will have applied to become a participant in MyHealth, and they will have been accepted as a participant in MyHealth, and most likely they will have applied for and received a connectivity fee award grant from the state, and that would be Steve's office. And then that will kick off the process you see here. You'll start to get phone calls, maybe from your customer, probably from your customer, unless you're willing to provide some contact information to the MyHealth team, because it certainly makes things more efficient if we can alert you all directly. And so My Health will provide the data integrations overview documents. Note the standard specs are also available on Steve's office's website as well, which is our ADT standard and so on. We did not provide a CCD standard because we just defer to the 2.1 CCDA requirements. And then we have a decision to make on the source side of the connection type. Is it going to be VPN? Is it going to be SFTP? Is it going to be WSDL? Whatever the approach might be. Complete the pre-paperwork to get that connection made. Kick off the integration. Make the connection. Then we need to be sent some test messages. They can be de-identified or identified. We can help handle either one. We tend to prefer de-identified just to start with. And if those pass validation of the data format, generally, which means they don't break something in the parser or the processing into the environment, then we proceed. If they do, then we make a loop back through to get the data structure or the message structures cleaned up. And then we go into portal data validation, which is really a data quality validation. And we're always adding more data quality checks to our process. So expect more news there. And then if there are problems, we'll iterate on that before go live. So that's the basic process. And we very granularly track the status of those so that you can know at any point in time, what the status is of an integration in its build. Next slide, please. So just want to emphasize data quality again, because we all know the very old adage, garbage in, garbage out. If we're going to put this much effort in, let's get the ball all the way across the goal line and have high quality data. This is sort of a conceptual picture. Next click. And what it shows is that obviously the provider has got to put the data into the right data fields in the EHR. We understand that. When we do data quality, we look for that. And then the EHR vendor, your organizations need to make sure that those data fields are mapped to the right codes and terminologies in your system, and that you're exporting CCDs, ADTs, ORUs in the correct structure so that we can get them. Then the data is transported to us, and you can see a whole series of steps and things that we do on the MyHealth side. And then the call outs at the top are things that can go wrong, elements that we check for in our data quality analysis as well. Next slide. And so the types of feeds we take in the full range of HL7 V2, not just the ones we've listed here. We also take in the so-called V3 HL7, which is the CCDAs. You can see a forest plot here of the relative feed count. This is not data volumes. This is just the number of feeds of each type. So 300 ADT feeds, for example, is what we have currently in receipt or that are in queue to be completed. And you can see the other data types there as well. And then I will emphasize that we consider single sign-on to be a feed type or an interface type. And that, of course, takes configuration and build with each vendor. We very much like to get a prototype done with each vendor so that we can quickly roll out customers on your platform. It certainly adds a lot to user satisfaction to have that single sign-on in place, so we really emphasize it. Next item. So I'll just reiterate, having done work with ONC and worked on the 21st Century Cures Act, I'm sort of embedded in these things. So I'll just reemphasize that as a certified EHR vendors, we expect data feeds that are CCDA 2.1. We expect the HL7 V2 messages standardized such as they are. And then we expect that all certified vendors have FHIR API access. We aren't currently making queries back to FHIR APIs, but we'd like to make sure that it's known and an option when needed to make sure the data stays complete for things like pandemic responses, natural disasters, and other things that might warrant us having access to additional data. And then the data contents itself. You may be familiar with US CDI, which is sort of the floor set by ONC for the contents of the information. And the expectation now is everybody's on version 2, making clear progress to version 3. The data timeliness, in general, data comes to us in real time. Often CCDs will be triggered upon signature or encounter closure to come to us as well. And then finally, the fees to the practice of the health information exchange. Part of holding this meeting, of course, with all of you and encouraging vendors to attend is so that we can try to get at economies of scale. It was beginning to look like every practice was going to have a large technology bill from their vendor, both a one-time and even potentially a recurring bill. And if certainly the objectives and expectations, I think, of the certification program are that interoperability is made easier and less burden on providers. So we'll do anything we can to work with vendors to target and achieve economies of scale, as I've already said. Make all connections for the vendor at once for the state of Oklahoma's, all the participants in Oklahoma, or other methods you guys would prefer that we do. I will say that the one-time fees are eligible for state funding under this connectivity fee award. Recurring fees, however, are not. So that's a new financial burden on providers that we really encourage you to work with us to figure out how to avoid. And then, of course, as with all things that require money from the federal government or the state, those costs will be known both to the state and the Fed at the ONC level for that interoperability. Anything you'd add there, Steve?
No, I just like to say, I mean, obviously we as the HIE have made it a very strong effort to be sure we're within the standards. So if your EHR is certified, you should have all the capabilities to get connected. And then, of course, our connection fee assistance program will pay for the time and effort it takes to actually get you connected. So those are the key things. And,
Right.
and like David said, reoccurring, state, we can't pay for reoccurring, we can pay for one time.
Thank you. Next slide. All right, so just to sort of cover some innovative things we do here in Oklahoma, the Board of My Health, on which the state participates, has issued a goal that Oklahoma become the first state with universally available social needs screening. And that is, and referral, of course, and that is built, tied to some innovative technology we've developed here. Next click, please. So My Health has developed a mobile device-driven social needs screening that can be triggered by clinical events. Go ahead and build that out if you don't mind. Next click.
Okay.
And it's a lightweight. It is the Accountable Health Community Screener, which is approved and certified by CMS for meeting MIPS requirements, by JCO for meeting their certification requirements, and others. And to the extent that HIE is requiring it, it's based on this as well. Next click. And so that screener goes to the patient. They can complete it in about 3 minutes. Any clinic or clinical operation who would like to have the screening turned on just needs to put it on their order form when they participate, sign up to participate in My Health, and we'll make it a part of their feed bill. The referrals that patients then get are tailored to their own needs and to where they live, so that they get a food pantry or shelter nearest to where their home is or where they are at that moment. And they get those, if the screening is completed, they generally will get their referrals within about a minute or 2 minutes of having completed the screening. So it's pretty much a real-time referral program. Next click. And so this program has been quite successful. In fact, we're now at 4.9+ million offers to screen and closing in on 1 million responses. Over 300,000 individual needs reported now and addressed. So it's been a very successful program for us. It reduces provider burden. It really saves a lot of time on the clinical side, but still makes sure that every patient gets their social needs met. And we've won national awards for this program. So we're pretty proud of it and want to help all of your customers be able to use this. And then, of course, we can route the data, the results of these screenings back into your systems. And we can talk about that in the planning for connectivity build. So next clip.
All right, David, thank you so much for those technical details. And like I said, this presentation, we'll share this as soon as we get into Q&A. And it's also be available online on our website, okshine.ok.gov. So I just wanted to talk about a few final things here. One of the big things that comes up and is actually a big positive of the HIE network is the governance. My Health has a very extensive governance system. They have a board of community stakeholders, in that board. The state actually has 3 seats of that board. There are several other committees that meet on a regular basis to roll up any changes to the organization or any changes to the system. Big one is, of course, Finance Committee, Privacy and Security Committee, Operations Committee, the Clinical Quality Committee, and the SDOH Committee. I would encourage anyone can be a member of these. So if you want to get connected to one of these committees and learn more information, you can reach out to MyHealth at their website. They'll get you enrolled. Actually, voting's based on attendance, so you can actually become a voting member if you can attend on a regular basis. So I think these are really good, lots of good information. If you want to get involved in how the HIE is organized or how the functionality works at all, we certainly encourage you to be a part of that. The other thing that we have a concept of that, particularly as we deal more and more with the EHR suppliers, is this Council of EHR Suppliers. We'd like to form a committee within that structure for those EHR suppliers that could help us with the governance around HIE connections to these EHR vendors. We want it to be connected to EHR suppliers to be a part of that, and we'll focus on standards and usability for that HIE integration, and also any of those things that you as a supplier might say, it would be a lot easier, or we could really cut down the connection times if we could do these things. So if you're interested in being a part of that council, please put that in the Q&A or reach out to us directly at the OK Shine address. The other thing I like to point out is, there is a thing called information blocking rules, and a lot of people don't understand those. And what is it? Well, it's really basically any practice that is unreasonably interferes or prevents the flow of information, or EHI in this case. It applies to all healthcare providers, IT developers, health information exchanges, and those suppliers. So as we see who's impacted, it does impact all of us, in fact. And here's some examples of those. So if you implement a technology that makes it difficult to exchange data, you're charging excessive fees for accessing or exchanging that data, you're using that EHI as competitive advantage, and withholding it from competitors, or you've established policies that restrict the sharing of that EHI data. There's a few exceptions to this rule. There are certain exceptions where blocking is permitted if it's going to prevent harm to a patient, if you're protecting privacy, if you're promoting security, and you're recovering a reasonable cost for responding to these. I only point these out because and we've had a few vendors that say, I don't need to do this. We encourage you that, yes, if you're asked to do this, you really should do it. And in fact, it's an information blocking rule violation if you don't. And so I'm not trying to be draconian. I'm just trying to state the facts. We haven't had a huge amount of that. Most of the EHR vendors have been very, very excited about getting connected and getting their providers connected. I think it enhances the value of that EHR system. And if you're trying to compete with the really bigs out there, this is a good way to do this, is to have that data shared in actually a higher fidelity format than Epics of the world can do. So some opportunities ahead of us. State funding for HIE has never been greater. We're very, very fortunate right now that we have this funding and we're able to use that, and it's kind of a use it or lose it. I think we need to take advantage of it while we have it. There's a lot of cost pressure on managed care, and that's going to push more and more providers to want to be a part, to manage their care gaps, to manage their notifications, to do those things that they want to do. And there's a lot of incentives to get those providers and EHRs connected. And it really and truly, it's never could you ever get connected at literally no cost and have your costs totally reimbursed through an incentive. And like I've said, and David pointed out, most of our incentives, as we look at them here for the first quarters, most organizations will receive 4 to 10 times what their annual participation fee would be in incentives. In some cases, a lot higher than that. So some of the risks we're facing, of course, is the legislature. We don't know what funding issues they're going to have. And anytime there are funding issues, there's always a tendency to go find money that somebody hasn't spent. So we certainly have, $20 million sitting out there that we need to, I need to spend it, but I need to spend it for valid things. So we want to get people connected. We want to provide these grants out there. The sooner you can get online and at least make your application. That'll get you in the queue, and we'll be able to at least ensure that that money is set aside for you. And what we need really is timely action by the providers. If you can really get out there and you can get that, it really help us out. It really help you out to get this in, even if it might be a few months before you're actually ready to get connected, get that grant qualified for. And then finally, just what are the value? As we've said earlier, the adverse drug events are a big part of what we suffer from, or our patients suffer from. Being able to see all meds in one place has a huge benefit, and that's a big thing that the HIE can do. Getting those preventative care alerts, or be able to send those out to your patients and providers, be able to know what preventative care is needed around a care gap. Speed and access to care. That ability to, particularly in patient intakes, to see that when you're taking that intake, being able to see the overall condition of the patient and where they've been and what treatments they've had. As we know, patients don't always tell you everything, either because they don't know, or they can't remember, or they don't want to. So being able to see that information can be a really big plus in the treatment of a patient. And having that social needs capability integrated, as David said, if you sign up for the HIE, you get the automatic, no extra cost. You can survey your patients with those social needs and supply those kind of resources. And then, of course, reduce the cost burden. Those co-pays from unnecessary visits and testing, no paper records to carry around with you. Those access records immediately for multiple use cases. I mean, how many of you have personnel who all they do is go try to get the records from other providers, right? That's a lot of faxing, it's a lot of calling, it's a lot of things going back and forth. Being able to get those in one place has a huge benefit, and it reduces that staff burden on providing those records to others, both going out and coming in. And then what the big thing, and I kind of alluded to this earlier, this really is a game changer for leveling the player field. The playing field is, having access, whether you're a rural provider or a provider not connected to one of the major EMR systems, you now have the same level, actually better access to higher fidelity data than those large systems do. And those advanced services you can get from MyHealth, like alerting, care gaps, SDOH, as a big plus. And that ability to perform in-risk and value-added based payment models, you can perform better those preventive care gaps, the quality performance. There are quality and care gap capabilities. If you really want to get it way into the capabilities here, and those alerting to follow-up opportunities post each ER visit and so forth. There's a lot of capabilities in the EHR. I know we've spent a lot of time going really, really fast through this. I'm sure you have a lot of questions, but what I'm really asking you to do, if nothing else, if you don't take anything else from today, go out to okshine.ok.gov, click on this orange box, connection fee assistance. It's not a very long process to make your application. That gets you registered. We typically turn those applications into approvals literally in less than a week. So in most cases, you're going to get it in a week or 2 weeks at the most. So get that out there, get yourself registered, get in the queue, and get your money established for you. And so in summary, improving care coordination and provider access is our key use case. That's enhanced assessment, closing those care gaps, enabling better follow-up, and enhancing that overall care management process. In doing that, you can reduce cost of care, you can address social needs, and you get timely access to care and services. So the HIE really does provide a path and to information for healthier Oklahomans. This is really what our purpose is. We want to have healthier Oklahomans. We don't want to be 47th, 48th. We want to be, obviously in the top 10, but this is a good way to get there and a major piece of that.